right. How many of you are here for the first time? Welcome, and I'm glad to have you here. And I'm really excited about this presentation. I am feeling bad that we didn't get the reminder calls out, but I'm hoping we still get lots of stragglers. This is probably the emptiest it's been in a long time, and it might be because of that. Okay, so I have news to share with you. So we started this series back in 2022 with one simple goal: to create a place where we can all learn, laugh, and make sense of this thing called aging. It's been a joy to see how much it's grown and how this community has embraced it. Over the past 3 years, we've hosted, next month is our last one, that'll be 35 seminars that we've done. Well, everything, thank you. A lot of you have been taught like all of them, so I'm very grateful. So we've covered everything from brain health to finances, end of care life, decluttering, and aging with a purpose. We've had hundreds of attendees, dozens of expert panelists, and countless other great discussions. I've been amazed by the connections that have been made here, and people finding the best resources and new friends and even new directions in life. It's been one of the most rewarding experiences of my life, and I'm very grateful for that. So what's new for 2026? Billy Encinitas, who I'm thrilled to share, is going to take over doing this seminar series in 2026. So I have loved doing it, but I really want to free up time to still do real estate, but travel with my husband. But my mom's 92, I want to have more time to spend with her. She has Alzheimer's. And so I was looking for how can I continue this seminar series on for all of you who've been so loyal and have that same thirst for passion that Rick and I do. And so, to be honest, they're probably going to do a better job. You know, they have all kinds of volunteers that can help them, and it'll be a good, fresh start. And so we have in the back corner, if you've been here before, Sandy with Village and Sandy, will you stand? So Sandy, thank you for being here. So I promise you, the heart and the mission of this series is not going to change. It's what makes this transition so exciting for me. We will still have honest conversations, trusted local professionals, and topics that matter to all of you. It will still be free. It will still be open to everyone. We welcome all caregivers and older adults because learning and community should be for everyone. So how are you going to learn about these? We still are going to have our website, the Senior Living Education Series, that you'll be able to go to. Also, if you stop by in the back and talk to Sandy, you can give her your information, and you'll be put on the list so that you find out what events are happening, not just this series, but what other events for seniors are happening. Also on the yellow sheet, you know, we have our wonderful feedback forms. Near the bottom, there's a place for you to check so that we'll make sure that you get notified of upcoming seminars that are coming. They're going to probably lay out the plan of, you know, what the first quarter is going to look like. It may be here, I'm not sure exactly where, but they're thinking that the first quarter or first 6 months will be here, but it might be somewhere else. And so there's going to be all kinds of topics and very similar to this. So I just wanted to say thank you, truly, for showing up, for learning together, for laughing with us, and for being part of something so special. I'm not disappearing. I'm going to be around, so I'm going to help mentor for the first 3 to 6 months if they need me. And I see what has happened here as proof that connection and curiosity and courage are all what you have shown and given me. So we'll still be around. Okay, so that's enough of me talking about this. So I am so excited about our panel today, you guys. Strokes are something that's really scary, and I don't know a lot about it, so I'm really excited to learn from them. But I do know it's important to act fast, but unless we know what we're looking for, We don't know what we don't know. You've heard me say that all other times. So let me have our panel come up, Jessica and Dennis. Yeah, you're gonna come on up here. And well, let's give them a hand. And thank you. So we're gonna start by having them just tell a little bit about who you are, what you do, and what brought you into that, the work you're doing. So Jessica, let's start with you.
Hi, I'm Jessica. I'm a stroke program coordinator at Scripps Encinitas. I am a nurse by training and then went to ICU and have been in this role for since 2017. I'm bad at math. But yeah, so now my passion is getting out into the community and teaching everyone what signs and symptoms of stroke are, but then also risk factors that you can control so that you're less likely to have a stroke.
Dennis.
Good morning. My name is Dennis Sikowski. I'm 58 years old and I have a 5-year-old daughter. I bring that up for 2 reasons. One, it speaks to my motivation to age with vitality. And 2, if any grandparents out there want to share photos of their kindergarten age kids, I'm available. I'm happy to swap photos. I have a phone full of photos. I happen to be, my day job is as a mortgage loan officer. I do all kinds of mortgages, including I do a lot of reverse mortgages, and I'm well versed in reverse mortgages. So if anybody wants to chat about that, I'm available. But the reason I'm here is because I had a brain injury when I was 10 years old. I am the co-facilitator of the brain injury support group at Scripps Encinitas, and I've been in that role, that particular role, for I think over 8 years now. And so that's how I met Christy, and that's why I'm here today.
Thank you, Dennis. So Jessica, we're going to start with you. Would you walk us through the most common symptoms of stroke and explain in the acronym Be FAST and help people recognize how that and respond quickly?
Yeah, so I think some of you were able to pick up a magnet, and if not, you can grab some on your way out. But we try to always teach the acronym Be FAST. So the first letter of the acronym is B. So any of these are a sudden onset. This isn't, kind of it's been building over months or days, but suddenly you have a total loss of balance. So all of this, I can think of this one gentleman that came into our emergency room and his only symptom was that he could not walk through the Costco, and he came in through the emergency room, just suddenly unable to, keep your balance, and that would be a stroke symptom. The next would be eyes, so all of a sudden double vision or kind of eyes stuck to one side or the other. F, I think everyone kind of recognizes as that facial droop. Once, it doesn't have to be once like the left or the right, but just the face drooping to one side. A is arms. We call that arm weakness, but it could also be leg weakness. And so again, sudden onset, one side isn't working either left or right. Next would be speech. So speech would be either slurred speech, like someone might sound like all of a sudden they've been drinking when they haven't, or just what we call a word salad. They are speaking clearly, but they, the words don't make sense. There's not a sentence coherent in there. Or they're just looking like they want to say something and they can't get any words out. And then last would be time. So if you experience any of these symptoms, we would want you to call 911. So let's go through the slides here. So I'm going to stand up so I can see what we're going. So stroke statistics, I think I'm not going to read the slide to you, but we have about 800,000 strokes every year. About 200,000 are recurrent strokes. Stroke is not the leading cause of death, but it is the leading cause of disability. Unfortunately, it does bring a lot of people into a nursing home if you do have a stroke. Survivors of stroke, there are 6.5 million stroke survivors. I always tell people, it's the beginning of kind of a new life in recovery. And then women are more likely to have a stroke, but they do think that tends to be because we tend to live longer. So you're most at risk later part of your life. So since we live 5 to 8 years longer than our male counterparts, we're more at risk for those 5 to 8 years. And then race, stroke is more likely to affect Caucasian, or more likely to affect the African American and Hispanic population than our Caucasian counterparts. So we'll go to the next slide. I work at Scripps, so our stroke certified health centers are Scripps La Jolla. That's where they do, I know some people are very well versed in stroke care. That's where we do our embolectomies and hemorrhagic strokes. I work at Scripps Encinitas. Scripps Mercy is a thrombectomy capable, also does those embolectomies, and then Scripps Mercy Chula Vista. You won't see Scripps Green on here. That's just because we don't have an emergency room, so they can't, by the regulatory bodies, we cannot have a stroke center without an emergency room. Go to the next slide here. I did want to just mention, because I get this a lot, especially at Encinitas and at Green, people will drive themselves to our urgent care or emergency room. But really, if you do think you're having a stroke, we want you to call 911 no matter where you are in the county. We all work together. We meet quarterly at any of these stroke receiving centers, whether it's Sharp, Tri-City, UCSD. We're all partners to make sure that you get the best stroke care. We all can take care of you, and if it's like an insurance thing, we'll get you to where you need to go once the emergency is taken care of. So what is a stroke, really? Stroke occurs when the blood flow to the brain is interrupted. So sometimes there's some confusion between like heart attack and stroke. I think everybody knows the cardiovascular system is related, but stroke is specific to the brain. And we'll go to the next slide here. So there's 2 types of stroke, 2 major types, and that's ischemic stroke. So that's like a block in your brain. So the blood vessel is blocked either by what we call an embolus, so a little bit of fat or whatever has broken off and traveled to your brain, or a hemorrhagic stroke, and that is the vessel itself has burst and now is bleeding into your brain. So ischemic is what most strokes are, that's 85%, and then hemorrhagic is about 15%. Because hemorrhagic, the blood is just so aggravating to the brain, that is usually associated with higher mortality. So we'll go to the next slide here. What are the signs of hemorrhagic stroke? They're a little bit different. We kind of went over the BFAST there, but hemorrhagic stroke really is that sudden onset of the worst headache of your entire life. That's what people come into my emergency room saying. We always want to get a head CT when they're complaining of, I think we've all had a headache here and there, but if this is just like otherworldly, that's when you need to come into the emergency room. More subtle signs are like nausea, vomiting. Sometimes they come into the emergency room and everybody thinks about, maybe I had sushi last night, but really if your nausea and vomiting is not getting under control, that can be a sign of blood in the brain. So our emergency rooms are well versed in this, so they'll take care of you, again, coming into the emergency room. And then lethargic or decreased level of consciousness. We've had patients where, a wife and a husband take off for work for the day, and maybe the wife is still sleeping. The husband says, oh, she's sleeping in, but then he comes back from work and the wife never woke up and is just totally kind of out of it. So that decreased level of consciousness is where we really get worried about a hemorrhagic stroke. What is a TIA? Has anyone heard of TIAs? Oh, good. So it used to be called a mini stroke, but really what it is, they think that there's a clot that still forms in your brain, but your body has natural ways of dissolving clots all the time in your body. So a TIA is a temporary disruption. And what distinguishes a TIA from an ischemic stroke is really, we get an MRI when you come into the emergency room, And if the MRI shows the stroke, then you've had a stroke. If the MRI is negative and your symptoms have gone away, then we call that a TIA. But what's scary about TIAs is that 3 to 10% will go on to have a stroke within 48 hours. So that's why we want you to come in, even if it goes up, because I hear so many patients, oh, this happened to me like a day ago or 2 days ago, and then they come in and it's not resolving. We want you to come in even if it resolves in 5 minutes, 10 minutes, because we want to get you as optimized as possible. If your diabetes are out of control, your blood pressure, whatever it is, we want to kind of figure out what's going on to kind of start the stroke issues and get that addressed while you're in the hospital and get you the most optimized during that 48 hours. You'll be in the hospital, the best place to be to take care of this. And really, we're going to talk about time, but if the symptoms do come back, you're in the place to get it treated. And then 9 to 17% of TIAs go on to have a stroke within 90 days. So it really is a warning sign for stroke, and it's really something to pay attention to and come in. All right, so who is at increased risks for stroke? And I always tell people that I talk to is some of these we can control and some of these we can't. Increased age, whether we say that we're still 32 or, whatever it is, we have a biological clock that keeps advancing. Our gender, like I said, women are slightly more at risk if you've had a prior stroke, race, but then there's the things that we can control. So even if you have hypertension, I give the example, my cousin, he has been hypertensive since he was 18. He played hockey, he was healthy, it's just genetic, he's had hypertension. But he keeps it well controlled and he keeps his blood pressure low with medication. So even though he has high blood pressure, he's keeping it controlled, so his risk factors are actually as low as they can be. So it's about controlling some of these risk factors, like the hypertension, the high cholesterol, the diabetes. I can't tell you who is going to have a stroke. I don't have a crystal ball, no one does, but I know that people that have uncontrolled hypertension, uncontrolled high cholesterol, uncontrolled diabetes, those are the patients that are the most at risk. If you've ever heard about a stroke belt, we don't live in it, thankfully, but the southeast, like Alabama, Louisiana, they just have more strokes because a lot of these risk factors are not controlled for. And then cigarette smoking, hopefully nobody smokes anymore. But hopefully you're quitting if you haven't heard, it's bad for you. All right, we'll go to the next slide. So again, controlling the risk factors that I mentioned. We want your blood pressure as under control as possible. This is kind of busy, but it used to be like we would let people ride like 140s and say, well, we'll take your blood pressure again next time. But really, we want your blood pressure as low as you can tolerate without getting symptomatic, which would be dizzy because your blood pressure is too low. So we want it less than 120 over 80. If you're just living at the 130, 140, that still puts you at risk for a stroke. So getting that under control. Diabetes, we want the hemoglobin A1C. I don't know if anyone's diabetic in here, but that's just the blood lab that they draw. And we want that less than 7. And then cholesterol, stroke specifically looks at LDLs. So optimally, we want that under 100. But then you can see here, the doctor would probably talk to you about a statin if you were above 100. But if you've had a stroke, we want it even lower than that. So, all right, next one. So we started at the end here, but this is the Be Fast again. So it's a great acronym. We want you to be fast if you think there's a potential for stroke. Again, I always welcome people if they think they're having stroke symptoms and then they aren't. We'll let you free later that afternoon, but we want to make sure that you've come to the right place to get the treatment if you can, if you're eligible for treatment. And then next slide. So I want to take you through what I call a last known well, because there are treatment options out there. There's medication, we call it either Alteplase or Tenecteplase, but we can only give it for 4.5 hours for an ischemic stroke. So everything is based on last known well. There's no test that I can run to kind of see when your stroke was. So we have an 81-year-old male. He goes to bed after watching TV around 11 p.m. He felt completely normal without any issues when he went to bed. He wakes up at 2 a.m. to use the bathroom and has right-sided weakness, so right side is not working. His wife believes he is having a stroke and calls 911. The paramedics ask, when was his last known well? 11. So we can only treat from the last known well. So at 2 a.m. he had symptoms of the right-sided weakness. But 11 p.m. he was neurologically normal. So thankfully, if he comes right to the emergency room, we still have some time to treat. We can treat within 4.5 hours. But again, if this is your loved one, we want you to come in as fast as possible. And it's always tricky when it's like nighttime because we don't know. And I'm always playing detective when people come in at like 7 in the morning because I'm like, well, when did you really wake up? And were you okay when you woke up? Because the medicine is a very aggressive clot-busting medicine, so we only want to give it if it's safe to give. So I think that might be the end. Next slide. Oh, good. So again, this just reiterates the stroke chain of survival. It's really calling 911 to reach the emergency care that you need. I know I work here at Encinitas and we have easy parking, and you think I live down the street and I don't want my neighbors in my business. I've heard it all. It's really, please just call 911 because I can never control what the emergency room looks like, but what I can control is what EMS calls to my charge nurse. And I do a lot of education, same as this, out with the EMS, different providers. And when they call ahead of time and say, this is a stroke alert, get everyone ready, instead of going to the triage nurse, and the triage nurse will also see you very quickly, but if you come in through the emergency room, I have the laboratory, the CT, the doctor, the nurse, I have everyone waiting for you, and everyone, like, we get you right to whisk you off to CT, because again, we need to make sure which kind of stroke you might be having. Not you, but a patient might be having either the ischemic or hemorrhagic. So we always want 911 to be called. And again, the last known well. So that's it. Thanks.
Thank you, Jessica. That was a lot of information. Thank you so much. So next, I'm going to have Dennis speak. He's a stroke survivor, and we'd like you to share your story. What happened, what recovery will look like for you, and what else you want others to know. Thank you.
That's fun. Thanks. Again, my name is Dennis. And the worst thing that ever happened to me occurred when I was 10 years old. I had a paper route in the 70s, and my boss on my paper route picked me up by the head, came up from behind me, and I was a little kid, grabbed me, picked me up by the head. And that led to a hemorrhagic stroke in my brainstem, my left brainstem. And so that left me with what's called right side hemiplegia, which means my entire right side was paralyzed. From my face down to my toes, I couldn't eat, couldn't speak, couldn't swallow, couldn't move anything on my right side. Couldn't be sat up because I would get dizzy. Eventually, when I could be sat up, they put my arm in a sling because they feared that it would fall out of the socket. And I was 10 years old, and recovery, especially, it comes slowly. I was out of it I was in the hospital for a long time, and then I spent a long time in a wheelchair. And when I really started needing to, well, first of all, the science and the art of physical therapy in the 70s is a lot different than it is now, and they're much better at it now. Also, my family didn't have means, which meant I didn't have insurance to have very much physical therapy. So I really didn't have much. And then when I was 13, 14 was when I really started needing to do my work on. I need to start doing the therapy. I need to start doing exercise. And I have an older brother who's 6 years older than me, who really rode me, like, you gotta do this. And of course, you tell a 13-year-old boy you gotta do something, it's like, no, screw you. I'm my own person, I'm gonna do it myself. So it wasn't really until I got to college, first year of college, first week of college, frankly, I looked in the mirror and realized, whoa, I gotta do this for myself. I'm not doing this for anybody else who's pushing me to do it. If I want the things that I want in life, I'm gonna have to buckle down and do the work. And I did, and I started working really hard, and I've been working very, very diligently and very hard ever since. No one else can fix you. If you have a brain injury, no one else can fix you. There's no magic pill. No one else, as much as they want to do the work for you, no one else can do the work. You have to do it yourself. And thankfully, I can stand up here and say that 48 years later, I continue to make progress. I can give you a list of things that I've improved on and made progress over the last year. And I continue to make progress. And that's one of the things that I try to harp on with clinicians, because we hear often in the brain injury support group that, yeah, this clinician or that told me that I'm gonna plateau. I'm gonna plateau at 6 months, I'm gonna plateau at 8 months or a year, and now it's 5 months and I'm freaking out because I'm about to plateau and I'm not gonna get any better. And so that's one of my first messages to people, is that there's no plateau. Plateau is nonsense. You keep on working and you keep on improving. And you have to put in the work. And I've run 2 marathons. I live a pretty vital and healthy life. I do all the things that they recommend doing in terms of exercise and eating and sleeping and everything. And you do everything you can like anybody else. And as I mentioned, as the father of a 5-year-old, I have now renewed motivation to be vital and healthy. And so I didn't meet anybody like me, anybody who had been through anything similar to me, until I was in my 30s, when I started volunteering as a mentor. So when I was a child, I never had anybody who said, yeah, I've been through this. These are the things I've learned. Try this, don't do that kind of thing. Just never was available to me. And then I started volunteering and seeing the power of how that helped people. And I wound up at Scripps Encinitas as a volunteer probably about, I don't know exact dates, but probably about 10 years ago. And I just started volunteering as a mentor, as a peer mentor, they call it, because I've been through a brain injury. And about 8 years ago, 2 years after that, I found my way to the brain injury support program. And so now I'm co-facilitator with Deb Pimpstone, who is a social worker at Scripps, and she does the official part, and I'm the volunteer, and we run the program together. And it gives me a couple nice advantages. One, I'm not an employee, I'm just a volunteer. And 2, I don't have any clinical experience. Although I've been doing this for quite a while now, I don't have a license to protect. So how does that translate? That translates to Deb, the employee, the social worker. She says all the right things. She says them correctly. She is appropriate. I'm not always. I'm more of the tough love guy, because I don't have any of that to protect, and I've walked that journey, and I continue to walk that journey. So I'll sometimes give you the harder truths that maybe somebody else won't deliver. And I find it's a pretty good partnership, I think. There are few things when people have strokes, hemorrhagic or ischemic, or other brain injuries, concussions or car accidents, or however someone comes on a brain injury, there's all kinds of different symptoms. And 2 people with very similar looking, if you look at their images, very similar looking brain injuries can have vastly different challenges as a result of those. So people have all kinds of different things that they have to overcome from a brain injury. You often see paralysis, you've often got speech troubles, memory troubles, cognitive troubles. But the one thing that is kind of universal with a brain injury is what we call, it's funny that I'm forgetting this, cognitive, what's what I'm looking for? Cognitive,
Decline?
no, sorry, it's really funny that I'm forgetting this word at this moment.
Cognitive clarity?
Explain what it is.
I remember it now, sorry. Cognitive fatigue. And I mean, I've been speaking for 8 minutes, and so I'm a little cognitively fatigued. So what that means is that pretty much any survivor of a brain injury, with any level of effort, whether it's reading or thinking about something or exercise, you're going to get really tired really fast. And so that's kind of the one universal. And we do have strategies for dealing with that are way more effective than doing nothing at all. A lot of people, especially you'll find men do it. I'm just going to push through because I want to finish this task or whatever I'm doing. I'm just going to push through, and it makes it way worse. And then you're going to suffer for 2 or 3 days. And I'm not kidding. 2 or 3 days people suffer through trying to push through something. So we have strategies for dealing with cognitive decline, but cognitive fatigue. But it's just there are so many. It's been such a revelation to me being part of this group, seeing people have the ability to share their story, to share their truth, and just unburden themselves with what they've been through, and then sit back and learn from other people. Well, okay, you've been through something similar, and so let me understand what your path to recovery has been and what your journey has been like, and let me share and help you understand what I've done and what's worked for me. And because one of the things I always tell people is that recovery from a brain injury it's not a linear thing, and there's no finish line. It's a marathon without a finish line. I will continue to be in recovery for the rest of my life, and frankly, I'm not upset about that. I came to a really interesting revelation about 2 months ago. And what I realized is that I'm grateful for the worst thing that ever happened to me. Because it's made me who I am. It's forced me to be the person that I am. It's forced me to put in the work and to rise to challenges and understand how to rise to challenges. And when I'm faced with new challenges, I have a different attitude now. I have an attitude of, all right, how do I turn this challenge to my advantage? How do I become a better person by facing this obstacle? And so I'm grateful to be standing in front of you, telling you that I survived a brain injury, and that I facilitate this wonderful group that I really, again, I'm so grateful for being able to run, because I get so much out of it, because I see people come through and I see their journeys. Again, being there for 8 years now and seeing people come through and very recent after a brain injury and really suffering, and then watch their journeys and watch their improvements. And I all the time I tell people, if you have a brain injury and you do nothing and you just do the regular therapy that they're going to help you with, you'll have some recovery and you'll improve. If you really focus on doing the work and you do your homework, you'll have a decent recovery. If you work harder than anybody thought you could, anybody gave you credit for doing, and you thought harder than you thought you could work yourself, you do amazing things, and you'll surprise everyone, including yourself, and you'll have a great path through the rest of your life. So I appreciate your attending and listening to me, and hopefully we can chat later.
Thank you, Dennis. I'm so grateful for your journey that you've shared and your personal, you can tell you're speaking from your heart, and I'm very grateful for that. Okay, so let's start with Jessica. You've shared a lot with us. Can you go a bit more detail of why acting fast is so critical when someone is having a stroke? What can happen if care is delayed even by a few minutes?
Yeah, great question. So again, I think I mentioned that we can treat with medication for within that 4.5 hours. But even, let's say you come in at 3 hours versus 3.5 hours. The studies actually show the faster we treat, the less likely you are to have disability when you go home. So we actually aim for the golden hour. So say you have symptoms right now at 10:47, our real goal is for you to get to our emergency room in less than an hour so that we can treat as fast as possible. Because we find when you look at the studies, the faster you treat, the less likely you are to have disability, which makes sense. We want that brain to revascularize rather than sit there with, not blood flowing to that part of the brain.
So Dennis, from a personal or clinical perspective, what does the recovery process look like after a stroke, and what kind of support makes the biggest difference?
Well, it's, as I mentioned, it's going to be different for everyone, and especially the different types of stroke that you've experienced. And so it can be relatively quick. You can be out of the hospital in a couple of days, or you might spend a month in rehab, or it just depends. As I mentioned, physical therapy is much better. But what I really, because our support group is open to caregivers as well as stroke survivors, brain injury survivors. And it's really critical that caregivers are part of the recovery process. One of the big things that we hear often is we'll hear people say 6-8 months out, I'm so frustrated, I haven't made any progress. And that's where a caregiver is super critical, because they can say, they have that perspective, and they can say, no, here's where you were 4 months ago or 5 months ago, and here's where you are now. By watching that progress and being encouraging of the therapy that you need to do, and keeping a mindful eye and a perspective on the process, on the progress, because from the perspective of the person who experienced the brain injury, it's tough to see, especially in the early days. It's tough to really track the progress and realize the progress that you've made.
Jessica, do you have anything to add to that?
Yeah, I agree, especially with the caregiver, because they're seeing it day to day, and they also a lot of times need the same, different type of support, but similar, to be able to see that there is progress, and just I think identifying other caregivers and maybe some struggles that they might deal with, and just getting that little bit of a telling their story too. I imagine that's very powerful. So I think I think Dennis has such a great attitude about it. It's just like doing the hard work to make your recovery your own.
Thank you. So Jessica, what are some of the most common risk factors for strokes, and how can people reduce those risks with age? I know you touched on it a bit, but can you go into any more detail on that?
Yeah, so the biggest risk factor, I will say, is usually hypertension and cigarette smoking. I made a joke about hopefully nobody smokes in here. But even if you were one of those people, if you quit, say you were a smoker up until today and you quit tomorrow, your chance of a stroke is cut by 50%. So that's a big one. Hypertension, it's about, again, getting it under control. We can treat with a vast majority of medications these days, and it's really just about getting those under control. Diabetes is the same. Diabetes is a big risk factor. And just making sure, I always tell people I think some people in general, hopefully not this group, but they think, oh, I'm healthy as an ox. I haven't seen a doctor in 10 years. those are the people that scare me the most because they haven't had their blood work drawn and they actually have no idea what their risk factors are. Like maybe their blood pressure is out of control, maybe they have diabetes. And my former life, I was an ICU nurse, and those were the people that just crashed and burned really quickly. So it's about going and taking care of yourself and seeing your doctor once a year. And it sounds boring, but getting your labs drawn, getting your blood pressure taken, and just seeing where you are. Because I just had a conversation at the gym this morning with a fellow doctor, and I'm not gonna say who it was, but she's an OBGYN. She's like, yeah, I had my cholesterol checked in like 2018. And I'm like, you're just supposed to have that done every year. And she is like, you are? Like, I mean, she should know this stuff, but she's so special. She's like, but I've been having my mammograms, like, of course, because that's her specialty. But sometimes we make the worst patients, but it really is just about seeing your primary care. They know how to treat all of your risk factors for not only like I'm specialized in stroke, like cardiovascular, but like cancer, whatever it is. It's about going and seeing them once a year. And, sometimes we take better care of our cars than ourselves. Like we have to go get that smog checked every 2 years, but like you need to see your doctor and just get all of these risk factors identified and hopefully managed in the best way possible.
It's really good to know all the different risk factors, and it's important for so many different health reasons that I didn't realize how much it affected strokes as well. Could you share the difference between, you did it briefly on what a stroke is and the TIA, the mini stroke, and why it's so very important to take seriously the TIA?
Yeah, so TIAs or mini stroke, it used to be called mini strokes. Again, it really is a stroke. It's just that your body has dissolved it quickly, and so that you don't have the lasting effects of the stroke. So that's great, but like I shared on the slide, it puts you at risk for another stroke event in the next 24 to 48 hours, but also in the next month. So that's really the time. Maybe I'm just throwing out examples, but maybe it's a TIA, but you didn't know that you had diabetes, or maybe you went from pre-diabetes to diabetes, and now it's time to add a medication or something of that nature to just kind of get those risk factors under control. Those are the things that we're really going to look for. We're also going to do a battery of tests, like is there anything going on with your heart? When you come in, it's not like we're just watching you for 24 to 48 hours. We're going to kind of run the gamut on maybe your heart. I don't know if I touched on this, but maybe your heart popped into atrial fibrillation. As we age, every decade after the age of 55, you're more likely to go into atrial fibrillation, which also is a big risk factor for stroke. So if you are in atrial fibrillation, a lot of times those are the patients on what's called anticoagulation. I think you might know Coumadin, but there's newer ones like Eliquis or Pradaxa. But we're just running those tests to kind of identify what possible risk factors have brought you in with that TIA, and we want to get that addressed so that we can send you back out into the wild with the lowest risk of a stroke.
So what does TIA stand for?
Oh, sorry, TIA is transient ischemic attack.
Okay. And if there's questions, we'll take them at the end, okay? Just jot it down, please. Thank you. I've heard TIA a lot, but I never knew what it stood for. Dennis, can you share more about the brain injury support group at Scripps and what kind of people attend, and how does it help recovering from a stroke or supporting someone who is?
Great, I really appreciate that. Of course, we're open to the community, regardless of where you've been treated. There is no cost to the group, and we meet in a hybrid model. So that means there's a conference room at the Scripps Rehab Center over by Home Depot, kind of in that area, in the Target Center. There's a big Scripps Rehab facility. And we meet in the conference room there, so we meet in person. But there is also it's a hybrid model, which means we also meet, that conference room has a conference capability, so it's got big TV and got camera and everything, so you can join us online on what's called Microsoft Teams. So you can join us online and participate in the group from your phone or from your computer at home. So we do have people from all over the county who don't want to drive in, even if they're close, don't want to drive in, who participate in the group. So those are brain injury survivors, and as I mentioned, we also really encourage caregivers to attend as well, because caregivers do also, most people, their spouses, and now all of a sudden my spouse has had a brain injury and I got to take care of them, and how do I do that? And they have a lot of the similar problems that the survivors do, and so they need support as well, and learning and understanding. So it's also really critical for those people to attend as well. We meet the second and fourth Tuesdays of every month at 2:30. So it's the second and fourth Tuesday of every month at 2:30. We meet in person in that rehab center and also online. If you want to join us online, you need to get on the email group because the link does change every week. Some technical reason that popped up recently, so it's a new link every week or every meeting, and that's when we meet. Did I answer all the question?
Yeah.
I forgot what the question was.
So the question was, how would you recommend stroke support? I'm reading the wrong question, sorry. What kind of people attend, and how does it help recovering stroke and support recovery?
How does it help? And that's a big one for me as well. Like I touched on, just being able to unburden your story and share your story with kind of a similar cadre, similar peers, if you will, have been through maybe something similar. First of all, just witnessing that and watching people be able to unburden sometimes can be powerful, sometimes it's not. But also learning from other people what's worked and what hasn't, and learning these strategies with cognitive fatigue, and we have guest speakers pretty much like maybe every other meeting we have a guest speaker, so we'll have somebody come and address aphasia, which is problem speaking. We'll have somebody come and address balance, and we've done things on returning to driving, if people want to return to being able to drive a car. I occasionally, once or twice a year, I'll do a session on goal setting, and just kind of every once in a while I'll go off on a philosophical rant about how I feel about recovery and mindset. So there's a lot of different ways that and it's not just for brain injury. It's been really well documented how support groups help recovery from various maladies, from brain injury to cancer to whatever you have you. So support groups are well documented to really help recovery.
Yeah, and that's how I met Dennis. I went to the support group as a caregiver, feeling very overwhelmed, and just being able to share your story and listen to other people and their input is priceless. So what you do is just wonderful. Plus the fact that if you can't get there physically, that you can do it via Zoom, which is just wonderful. And at your table, you have information on how people can find out about it. Do you have that at your table afterwards that people can stop?
Yep, we do. We have a flyer. I don't think the flyer actually addresses the time and dates of the meeting, but I've got my card so anybody can reach out and contact me.
Do you have more to add about the support group, Jessica?
I also have plenty of resources, but again, I think they wanted to make the flyer in case it ever changed. So there's a phone number on there, but he knows the dates and times better.
Yeah, so
I'll
that's
talk to marketing.
So my next question to you, Jessica, is what community resources and rehab services and programs would you recommend for stroke survivors and their families?
Obviously, I recommend Dennis's group, but Encinitas is really, really blessed because for whatever reason, we have had a lot of investment. There's not only the brain injury support group, but there is like an improv group, there's an art group. The rehab center has quite a few different supports. I also have a flyer that has other resources, because I know Sharp has resources, Palomar has resources. And even like nationwide, there's like an aphasia group, and I don't want to list them all, but I think getting the support, I think obviously the best group would be locally because it's so much easier. But you know, American Heart offers a number of support as well. That's all listed there. And I know Dennis talked about like brain injury or getting back to driving. So we have a little bit about that. So it's like a 4-page flyer, but there really is a lot of support out there for stroke because we do know, to Dennis's point, that participating in a group session really just helps motivate, helps keep you on track. I love the idea of goal setting. Because I know as a nurse, when I was at the bedside, people, it's so easy to get frustrated, like I can't do this, I can't do that, but really, what can you do and what can we do today to see that you are achieving a goal and you did work with physical therapy, and maybe you can't walk 100 yards, but maybe you can take five steps in the room, but maybe tomorrow we can do 10 steps. And it's really about setting realistic goals and, you know, working with a group that's been there and done that.
Thank you. So both of them have information at their table, so make sure and stop by. Even if you don't think you'll need it, you might talk to someone that knows somebody that could use that information. So my next question is actually for both of you. We'll start with you, Jessica. Before we open it up for questions and answers, what's one piece of advice you wish more people knew about strokes, whether it's recognizing symptoms, responding, supporting recovery?
All of the above. No, it's really about identifying a stroke. We look at studies nationwide, and only about 50% of people will actually call 911. And that's why I do these events and come out to talk to people that aren't in the healthcare field, because we know that only about 50% can identify a stroke if they saw one. And a lot of times, if it's your brain or my brain, I can't recognize my own deficits at times. Maybe I can, but there's a certain part of the stroke that you wouldn't even notice, even if one whole side of your body doesn't work. So we really rely on caregivers or support people. And I love to share a story. We had a patient, and it was a nanny, and she was a nanny of small preschool children. And the preschool children obviously didn't know the word stroke, but they knew that something was vastly wrong with their nanny when one side of her body didn't work and she couldn't talk at all. So they knew to call their mom, and the mom called 911. So these two preschool, they were twins, these two preschool girls that were like 4 years old had the know-it-all to call their mother at work and say something is wrong with our nanny, you know, insert whatever her name is. But they saved this woman's life, and you know, she came in, she got treatment, she had an embolectomy, and you know, she was back to work. I don't remember when, but she had a meaningful recovery and didn't end up in a nursing home. And so that's why I come out and teach to anyone who will listen about stroke signs and symptoms, because if you identify it early enough, there are treatment options.
Thank you. Dennis, I'm going to repeat the question. One piece of advice you wish more people knew about strokes, whether it's recognizing symptoms, responding, or supporting recovery.
Yeah, so I'm more focused on the recovery side. And what I'll say is that there's no one, even the most blessed person in the world, no one skates through life without trauma and major things that they have to overcome. You never have to look far to find somebody who's got it way worse off than you do. So it's always important to retain that perspective. And what's important to me from my perspective is not the challenges that you're faced with, but how you address them and how you face them and how you set goals and how you struggle and plan and work to overcome those goals. Whether it's a brain injury or whatever malady befalls you or your family or whatever things happen to you, it's the same perspective. How do I overcome this? How do I face this challenge? And so that's the kind of attitude that I bring, while of course understanding that you're facing something tremendous that, you know, probably the worst thing that ever happened to you, but it's still something that no one can do for you, that you have to do for yourself.
Thank you so much. So we're going to open up for question and answers. And so what I'm going to do is have you raise your hand. We're going to have them run around with microphones. Chris is grabbing one. Karen. Dennis got it. Okay, we're good. Okay, so who's first? Okay.
Hi. Sorry. I'm not sure if this is on.
Yes, it is.
Okay. So in 2020, I had a stroke, and through emergency room, I was taken because they thought I was having a heart attack, and they admitted me. But after several tests, something about the enzymes or whatever, I don't know what they were talking about, it was a stroke. I was there for a little over 2 weeks, and then I didn't go to a rehabilitation. My sister took me to live with her because I was alone, and for over 6 months I was with her. I had a visiting nurse 3 times a week. I had OT and PT because I had to learn to dress myself again and all that. I had no movement on my right side. So I knew what that was. But then I had a TIA in August. I had no clue. I just knew something happened to me, but I didn't know what. It's not like I was sick or anything. I went to my doctor 3 days later, and she was like, that's a TIA, and you've already had a stroke. You have to be more aware. And she explained a few things to me. And that was scary, because there's no symptoms like heart problem or numbness or you're falling on the floor. It was a totally different where I lost an hour of time and didn't know what the heck was going on. And for the next 3 days, I was like in loopy land. So I don't know what people do with that.
Is there a question?
Yeah, what do people do with that? Like, for any little thing now till you run to ER? I just don't understand that piece.
Thanks for sharing your story. Yeah, unfortunately, stroke really can come out of the blue without much of a warning sign, or the TIA. And I think it's really like a sudden, like I try to teach, it's a sudden change when you know something is wrong. It's not kind of the day-to-day. I feel a little, maybe you feel dizzy, maybe you're on some cardiac meds, but like a sudden change that it sounds like even though it was a TIA, you knew something was wrong. Those are the times that you do want to come into the emergency room. I know I'm paranoid every time my arm falls asleep in the middle of the night. Like I'll say it because I work in this field. I'm like, is it coming back? Do I need to go to sometimes I'm laying awake at 2 a.m. till 2:30. You know, you just have to kind of be vigilant about what the symptoms might be.
Thank you.
Okay, Chris? Yeah.
Can someone define what cognitive fatigue is?
I'm happy to take that. So it's pretty universal after a brain injury that any effort, whether it's reading, watching TV, speaking with somebody, exercise, walking, anything, will make you, it's a fatigue like you just ran a marathon. You cannot believe just how overwhelming it is. And the best strategy for dealing with that, kind of in a summary, is the moment you feel it coming on, to stop and rest for 10 minutes. Close your eyes if you can for 10, 15 minutes before resuming, because if you push, the longer you push, the longer it's going to take to recover from that. And it's pretty much the only universal in brain injuries is that you'll experience cognitive fatigue. And I mean, for me as a 10-year-old, I was unbelievably tired for at least a full year. And my deficits were not cognitive, my deficits were physical. And I still had wild cognitive fatigue.
Karen?
Thank you both very much for this wonderful presentation. Dennis, you look fabulous. Never guessed you had such a challenge. I want to share quickly that recovering from an injury, I wrote down every day what I could do that day that I couldn't do the day before, and it really helped me focus on those little things. But I would love to hear your list, or part of your list, of improvements you've made just this last year after so many years of this lifelong rehabilitation.
Thank you for the question. Well, the thing that I've been focused on for the last year has been my gait. And I have always struggled with being able to activate my hamstring, be able to voluntarily activate my hamstring. So like if you're lying on your stomach, you'd be able to do a leg curl behind you, lift your heel up towards your butt. Couldn't do it. And I would always I'd hitch my butt, hitch my back. Couldn't do it. And after changing some specific exercises and getting on a different routine for it, I have it now. I have that voluntary activation of that hamstring, and it's really dramatically helped my gait. And this is, again, my brain injury happened when I was 10 years old, and now I'm 58, so I'm continuing to make progress, which is kind of the main message that I want to get across to people.
Thank you. Are there any other questions? Okay. We have one back there, Karen, or Chris. This will be after the.
Yeah, thank you. I have had 2 TIAs. And I want to start by just saying, Dennis, what a role model you are for our community. So I would like to emphasize the idea that your symptoms can be different from anything that you have heard here today or that you read on this piece of paper. My first one, but what's important is the balance, eyes, face, arms, speech, time. That's what's important. The notes after those can be specifically different. So for me, I was reading something on my iPad and I could not understand what I was reading. And I knew something was wrong because I just couldn't understand it. Then my speech became slurred. But a hint I have is that Dawn and I have hanging inside a cupboard door in our kitchen a list of stroke symptoms. And we went over and opened that cupboard and went through the symptoms. And then I went to the emergency room. And I want to say that both times we've gone to Scripps emergency room, and I want to thank everything that you do because the emergency room was wonderful for me. I think that's what I just want to say. I don't have a specific question. But I wanted to give that hint and say how appreciative I am.
Thank you.
Thank you. So, Karen, you had someone? Oh, yeah, I'm sorry, Chris, yeah.
Okay, so there's a lot of emphasis on the LDL cholesterol, which was on your chart. And I'm just trying to understand, if you're not to borderline yet, it still seems like there's a lot of emphasis from cardiologists to put you on a statin or something. I'm already tried 2, and the side effects have been pretty bad, even at the beginning dose. So is there anything you can do with diet and things I exercise and I try to eat Mediterranean, but is there something we can do in conjunction with medicines to get our LDLs low?
Great question, and I know there's a lot of hesitancy at times about statins. So if you're not tolerant, I always kind of say if it comes to statin, obviously start low, but there are side effects to every drug is also, every pill is also a poison to a certain extent. So the Mediterranean diet is kind of the one diet that cardiologists and neurologists go back to because it shows the biggest efficacy to kind of lower your cholesterol. There's also, again, I'm not anyone's provider here, but there's also like red yeast rice is more of an Asian that has similar efficacy to lower cholesterol. But really just work with your primary care or your cardiologist. If one doesn't work, perhaps a different one. I know there's also like, not necessarily a statin, but and now I'm blanking. Like Lovaza, I want to say. There's other drugs out there. Yeah, there's the new one that is like a shot that's like once a year. There's always kind of new medications. So it sounds like you're borderline, so I think just working with those specialists, but also, you know, just you've got to be okay with your management moving forward. If a statin is not working for you, then either try something else or figure out how you can do it with diet. But some people, I think the point of the graph is some people are not borderline, they're more like, I don't know, 140, 150, and those are the people we really, really want to get under control.
So Jessica, thank you, and I just want to throw in before, while it's on my mind, a disclaimer. You know, it's like talk to your doctors. This is not medical advice, this is to make you aware of things, but please talk to your medical physician and get, you know, what they're saying to do.
I just wanted to know if there's, while you're waiting, you call 911. You call 911. Is there anything you should be doing in the meantime? Or if you're with the person, is there anything you just wait? Or I know like for a heart attack, I'm not sure what you're supposed to do either while you're waiting, you know?
Really, the dispatchers are really great at giving advice for what the symptoms are. A lot of times with stroke, what we need to do immediately is get a head CT, and no one has that in their living room. So it's really supportive care. Like if they are having trouble with one side, make sure they're like getting seated safely. Like if one side of their body isn't working, but really that they should be there quickly, and it might seem like an eternity, but really it's just supportive care at that point until we can get the tests that we need before we can make decisions. We don't want to give them any, I'll just be clear, we do not want to give them any medications, because what would treat one would hurt or exacerbate the other. I've heard some people for heart attack, I give aspirin, so I would do the same for stroke, and that's real. You don't want to do that for stroke. First of all, because they're swallowing, without you knowing, their swallowing might have been affected. So it's really dangerous to give them something to drink or a pill. And so really just kind of making sure that patient is safe until 911 gets there.
I just want to make a comment. If you call 911, the best thing you can do is unlock your front door.
That's a great point.
Because they can't help you if they can't get in.
Yeah.
Or have somebody else unlock the door.
Yeah, so her comment was if you call 911, I don't know if everyone heard, but make sure you unlock the front door so that they can actually get into your home. Which is, I've never thought about that, but that is a great point. You don't want to lock them out if they're there to come help you.
Hi, I guess this is for both of you, Jessica and Dennis. I was very disheartened to hear that providers are saying that you plateau after a certain period of time. Why, I mean, I know some people do, but I wouldn't think that's the case with most. Why do you think they say that, and how can, and I know people tend to believe everything the doctor says. It's not always true, or they need more information. So how can we change that? Is there any way to have them not tell their patients that?
I'll start. I haven't looked at the specific data, but I am guessing it has something to do with you are provided a certain amount of insurance for PT and OT, and once that expires, I am guessing that the studies show that you're plateauing, but really what is likely happening is that you're not working with PT and OT or speech or whatever as frequently. I know it's Dennis's mission to change that, but I'm guessing the studies are actually reflecting what is more likely a lack of insurance covering the more advanced work, the PT and OT.
Yeah, as Jessica mentioned, it's one of the things that I do. It's one of my things that I'm trying to get at, but it's difficult to get in front of groups of clinicians to get my message across. And of course, as I mentioned, this is I have a day job, and so it's a challenge to get in front of the right groups of people to get that message across. But I am working on it.
Well, and one of the things that I found out recently is Medicare, it used to be that you only got like 12 physical therapy, and now you can get more if you're a senior, which I think most of us are. So that's something to look into.
I guess I'm extremely fortunate. I had 2 small strokes in 2012 while in the hospital. That Sunday morning, I passed out in church. Paramedics took me to Scripps Encinitas and determined right away that I had AFib, irregular heartbeat. And I was ready to go home after that, but they, of course, wanted to keep me for a while for observation. That same evening, or I should say next morning, probably about 2 or 3 o'clock in the morning, they came in to do an EKG and blood pressure, and all of a sudden I could not talk. And I'm sure they must have recognized it as a stroke right away. You know, I just couldn't communicate. I was going to say, I was fine when I got here, what have you done? In any event, it was determined 8 hours later after an MRI that I, of course, had a stroke. But my dilemma is, I called the hospital, not immediately after, but sometime after that, I was trying to determine, they have some kind of procedure that they can administer, just what you would do if somebody came in to emergency, I suppose. But I never could get any feedback from them as to what transpired. But I pretty much fluffed it off because I said to people, yes, I had a couple small strokes, not TIAs, strokes, but I had no side effects. So I have not really given it that much power over these last 13 years. I'm aware of the symptoms and so on. But again, I could never get any feedback from the hospital as to what transpired when I was there.
So I wasn't there in 2012. But it sounds like you possibly woke up with the symptoms. So I'm not sure. But again, everything comes back to last known well. So if you were outside of the 4.5-hour window from when someone saw you, again, when you're sleeping, everybody is really at risk because you're not getting up and doing a check on yourself for 8 hours, usually at nighttime. But they also may, because of your AFib, they might have also anticoagulated you, which may have, this is all speculation again. If they give you anticoagulation, you wouldn't be able to be treated with the thrombolytic, the tenecteplase or the alteplase. There are procedures that you alluded to, the thrombectomy, which I kind of said there's 2 in Scripps La Jolla and Scripps Mercy. So that is an intervention that they go up through your groin and essentially put a catheter up into your brain and pull the clot out. Those interventions were not approved they didn't show efficacy. Science is always evolving until about 2017. So that is kind of the newest and greatest since 2017. So that's why you're seeing more centers kind of develop that capability. As far as Scripps Encinitas, we do have a great transfer process. So we'll get you to Scripps La Jolla very quickly, essentially.
Which didn't happen, of course. So I'm just giving it all to divine intervention.
It sounds like you've had a great recovery.
Okay, yes?
Yeah, under the Be Prepared, which I love the handout, this is really helpful, but under Be Prepared, since we're calling 911, I was just thinking it'd be nice to maybe add, like, where should we have our pulse document if we have a pulse, and or our advanced directive to make sure we get the desired care that we want.
Where should that be?
I've never experienced that. That's a great question because sometimes we go through it, but as far as stroke treatment, we usually treat no matter what, because we figure that no one wants half of their body with what we call hemiparesis. But when it comes to more advanced, I do like that idea of having a pulse, but I'm not sure where everyone might keep it. I know some facilities do a vial of life. Has anyone heard of this vial of life in the freezer, where you keep all your important forms in the vial of life? I feel like a copy of your pulse in that vial of life would be probably the best place to place it, because I know EMS will look for that if you have like the sticker to look in the freezer for that vial of life. In case, for those who don't know, a vial of life is like a plastic form, and hopefully you keep all of your medications and your allergies up to date in that one it's like a sandwich bag, but it says vial of life on it. But you would also want to keep a pulse form in there as well.
So we're gonna cut it off there. As you guys that have been here know, I try to keep us right on time. So I want to thank our panel. Can we give them a hand before?